Welcome to the Symposium 5 Critical Care, which is an important symposium. The first talk is on oxygen and ventilatory support in acute respiratory failure. And I'd like to invite Dr. Sin.Man Lam, a specialist in critical care medicine, consultant, Department of Intensive Care, Pamela Yo, Netsol, Eastern Hospital, Hong Kong. Over to you.
Thank you. I must congratulate the college for holding this successful event, and thank you very much for having me here. I'm enjoying every bit of my time here. So my topic is on oxygen and ventilatory support in acute respiratory failure. So because of the time, I will mostly be focusing on non-invasive respiratory support in acute respiratory failure and before intubation, and how to achieve safe ventilation after intubation. And the discussion will be largely based on ARDS studies. So we now have a repertoire of respiratory support, from non-invasive conventional oxygen therapy to nasal high flow to non-invasive ventilation NIV, and eventually going on to intubation and invasive mechanical ventilation. We won't be talking about extracorporeal support in this session. In acute hypoxemic respiratory failure, the Florali trial was published in 2015, and it compared conventional oxygen therapy with high flow and NIV. And although the primary outcome of preventing intubation was not statistically significant, we do see a benefit of high flow oxygen in a subset of patients with more severe hypoxemia with a PF ratio less than 200 millimeter mercury. And also the secondary outcome of day 90 mortality was also significantly reduced in high flow nasal oxygen. And since that study, the uptake of high flow nasal oxygen, or the use of high flow nasal oxygen, increased considerably, especially augmented during the COVID pandemic. And we can see from this more recent meta-analysis that when compared to conventional oxygen therapy, high flow nasal oxygen do reduce the need for escalation to invasive mechanical ventilation, although it does not improve outcomes like mortality and length of stay. So it is the recommendation by professional bodies to use high flow nasal cannula over conventional oxygen therapy in patients with acute hypoxemic respiratory failure. They also went on further to recommend the use of high flow nasal oxygen over NIV in this setting, and it was largely based on the Florali trial. But the Florali trial was also criticized because of the lower intensity of NIV used. It was used on average 8 hours per day, and also the PEEP level was a bit lower than what we would usually use. So again, because of the availability of patients during the COVID pandemic, there was more evidence accumulated on this topic. And in the recovery RS trial, we see a comparison between CPAP with conventional oxygen therapy and high flow nasal oxygen with conventional oxygen therapy. And we do see a significant benefit with the use of CPAP in terms of the primary composite outcome of tracheal intubation and mortality within 30 days. And in the secondary analysis, where CPAP was compared to high flow nasal oxygen, actually CPAP did better to reduce the composite endpoint, and it was largely driven by reducing the need for intubation within 30 days. In another study, the Hannaford trial, which was carried out in Italy, they used helmet NIV and compared this to the use of high flow nasal oxygen. Although the primary outcome of day 28 respiratory support 3 days was not different between the two groups, we see that the high flow nasal oxygen had prevented less patients needing the intubation compared to helmet NIV. And it was based on these various studies that accumulated into the more recent ESICM, or the European Society of Intensive Care Medicine ARDS guidelines, supporting the recommendation of high flow nasal oxygen over conventional oxygen therapy in acute hypoxemic respiratory failure. There was no recommendation, unlike in the ERS guideline, of either high flow nasal versus NIV in the same setting. But in COVID-19 patients, there was a weak recommendation for CPAP or NIV over the use of high flow nasal oxygen. So this was the difference from the ERS guideline. So we've talked about mostly acute hypoxemic respiratory failure. What about other settings of acute respiratory failure? Notoriously, the NIV has been used as the first-line treatment for patients with acute respiratory failure due to cardiogenic pulmonary edema and also acute exacerbation of COPD with hypercapnia. But this recommendation was based on a comparison with low-flow oxygen therapy. And now with a new player in the field, high-flow nasal oxygen, has the landscape changed? So again, we see a more recent randomized control trial, the RENOVATE trial, that compared patients with acute respiratory failure, whatever cause, comparing them, randomizing them into either using high-flow nasal oxygen to NIV. And these patients were classified and categorized into 5 different categories according to the course of acute respiratory failure. They were either having acute hypoxemic respiratory failure, but they were immunocompetent, or they had respiratory failure, but they were immunocompromised, or they had respiratory failure due to acute exacerbation of COPD, or it was the cause was due to acute cardiogenic pulmonary edema or hypoxemic COVID patients. So overall, we see a benefit. We don't see the two modality was non-inferior to one another. So they seems to be quite equivalent. But if we look at the subgroup analysis, we look at individual subgroups, we see that patients with immunocompromise, acute hypoxemic respiratory failure with underlying immunocompromise, they did not reach the non-inferiority margin, and randomization was terminated very prematurely, and therefore the number enrolled was very small, and we could not make a conclusion for this group of patients. Although the other 4 groups did reach non-inferiority, but if we look at those patients with acute exacerbation of COPD, we see that the confidence interval included quite a significant important difference in terms of there might be significant harm with the use of high-flow nasal oxygen if the patient was having an acute exacerbation of COPD. And the study also allowed crossover. So if the patient on acute exacerbation of COPD developed distress, they were allowed to cross over to NIV group. So this also raised concern of whether high-flow nasal oxygen was in fact safe in this patient subgroup. And there seems to be benefit towards high-flow nasal oxygen in the group with APO. But note that patients who already needed NIV to start with before randomization was actually excluded from the study. And again, these patients could be crossed over to NIV subgroup. So there is also concern that high-flow nasal oxygen might be useful in patients with less severe APO, but might not be applicable to patients who had more severe APO exacerbation. So up to now, we will tend to continue using NIV as first-line treatment for patients with AE-COPD as well as APO. So moving on to patients who eventually failed non-invasive respiratory support, needing invasive mechanical ventilation. We look at the recent ARDS guidelines issued by the ATS as well as ESICM. They were largely concordant in terms of using early prone positioning as well as lung protective ventilation using a low tidal volume. But there was some discrepancy in the use of PEEP titration. which we will look into further. So in patients with ARDS, or even in patients who are at risk of ARDS before they develop ARDS, low tidal volume ventilation has become a standard after the publication of the ARMA trial. And because with a low tidal volume of 6 mL per kilogram of predicted body weight, keeping the plateau pressure less than 30 centimeters of water and achieving permissive hypercapnia in some of the patients, the mortality could be reduced by more than 8%. So this is now the standard for our patients. And subsequently, the finding that the driving pressure was the independent predictor of survival, more than plateau pressure, more than PEEP. And therefore, the current recommendation will also suggest to keep a driving pressure less than 15 centimeters of water. But the story with PEEP level or PEEP titration is more controversial. It's not as simple as the low tidal volume ventilation. Whether we use higher versus lower PEEP, there is a debate on this topic. In earlier studies in the alveoli trial, in the LOVE trial, in the EXPRESS trial, we do not see a benefit, a mortality benefit with the use of higher PEEP, even in patients with moderate to severe ARDS. One of the reasons might be because there is a diversity in how we titrate PEEP, and also a diversity in whether we use lung recruitment maneuver in these patients. So in a more recent meta-analysis, we see that the analysis was different this time. Instead of lumping everyone together in one higher PEEP group and one lower PEEP group, the effect of lung recruitment maneuver was teased out. And we can see that using higher PEEP without lung recruitment maneuver actually improved survival compared to lower PEEP. But if you incorporate a lung recruitment maneuver, especially if this maneuver was prolonged for more than 60 seconds, there is a very high chance of harming and a very high chance that it's doing worse than just having a higher PEEP without lung recruitment maneuver. So this was the basis for the difference in recommendation between the ATS and the ESICM guideline, where in ATS, which was published after this meta-analysis, it also recommended higher PEEP for the general patients with moderate to severe ARDS, whereas in ESICM, they could not make this recommendation because it was issued before this meta-analysis. So even though we know that for the average patients with moderate to severe ARDS, a high PEEP might benefit, but we know the response to PEEP is very heterogeneous because it really depends on whether the increased level of PEEP applied to the patient's airway can open up the atelectatic regions instead of overinflating the baby lung areas, which would otherwise increase the stress and strain and also have subsequent ventilator-induced lung injury. So it makes physiological sense to titrate the PEEP according to response to it. And personalizing PEEP may become the future. But how do we predict this PEEP responsiveness? We can do it using ARDS subphenotypes. We can do it using lung imaging. We can also use lung mechanics to do this. So Professor Kelfy's group in overseas has shown that the PEEP response differs according to different subphenotype of ARDS, but that the differentiation needs to take into consideration the various cytokines. And more recently, machine learning can use readily available clinical parameters. But right at this moment, we're still not ready to use that. Another method is to differentiate whether the patient has local or focal versus non-focal or diffuse ARDS, as in the LIVE study. So in this study, patients control group received a set of standard ventilatory protocol. Whereas in the personalized treatment groups, they separated patients into either focal or diffuse ARDS and then applied the ventilator protocol according to whether they have focal or diffuse ARDS. The primary outcome was not different, but they found out that initially these patients were classified by local investigators, and many of them were misclassified when experts looked into it. And therefore, if the analysis was redone by classifying these patients correctly, there was actually a survival benefit in the personalized group. And what is more interesting is that if you classify these patients wrongly, the survival is even worse than the control group. But we cannot use CT scans to classify our patients, all our patients. It's not practical. So one of the ways we can use is lung ultrasound. And you can use various protocols as shown in this study, but they also show that lung ultrasound score more than or equal to 2 in the anterior areas, which predict a patient having non-focal lung morphology or diffuse morphology. There's also, you can also differentiate patients using response to PEEP, using lung mechanics. We can look at the hysteresis response using pressure volume loops, quasi-static pressure volume loops. We can use nitrogen wash-in, wash-out technique to look at the end expiratory lung volume difference with 2 levels of PEEP. You can also use EIT to look at overdistension and collapse. But all these methods, you will need dedicated ventilators with softwares. It might not be applicable, might not be available to many of us. So recruitment to inflation ratio is a method that can be done on all ventilators. You just need to drop the PEEP from a higher level to a lower level and to look at the recruitable volume and calculate the compliance ratio. So this is a possible method to classify whether the patient is recruitable or not recruitable at the bedside. But the downside is it's not it's not granular. It lacks detailed information. You don't know which PEEP level it should be in between. So this is one of the downside. But it gives you a rough idea whether the patient is a high recruiter or a low recruiter. So hopefully we will be seeing more evidence whether this dedicated protocol using lung mechanics will make a difference to our patients. One of these ongoing multi-center randomized control trial is the CAVIART study, which use recruitment inflation ratio as one of the criteria to personalize ventilation in patients with ARDS. So in conclusion, non-invasive respiratory support prevents intubation, but evidence is lacking on its preventing mortality. But this is a clinically important outcome that we do want to include. And also regarding the choice of non-invasive respiratory support in terms of acute hypoxemic respiratory failure, NIV and high flow seems to be fairly similar over conventional oxygen therapy. But in COVID, there is evidence of benefit with the use of NIV, although weak. But for AE, COPD, and APO, I would stick to NIV as the first line, and only if the patient cannot tolerate or during NIV breaks will I switch to high flow nasal oxygen. It's not lung protective ventilation, and personalizing PEEP is a way to ventilate our patients safely. Thank you.
Thank you very much, Dr. Lam, for your excellent presentation. It's my pleasure to introduce our second speaker of this symposium. She's Professor Vasanti Pinto, Professor of Anesthesia and Critical Care, Faculty of Medicine, University of Peradeniya, and Teaching Hospital, Peradeniya, Sri Lanka. And she's going to talk about practical weaning strategies. Over to you, madam.
Thank you very much, Chairperson, for the introduction. And I would like to thank the Chair, the President and the Council for selecting me to deliver this speech. And I'm interested to talk about the practical weaning strategies which is being used currently and in future. We all know prolonged weaning from mechanical ventilation associated with very poor clinical outcome. Choosing the right moment for weaning and extubation is essential. And reintubation is a common adverse event observed in the ICU with significant implications for patient outcomes. Let me quote one study, WeanSafe study. They found weaning from the mechanical ventilation in across the multi-center study was found that it is very high. The failure rates are very high with very poor outcomes. It's only 65% were successfully weaned from invasive ventilation. And overall, 31.8 patients died in the intensive care unit and 38.3 died during the hospital stay. So without further ado, we all agree this is a critical situation. And in addition to that, this study found higher sedation levels were also independently associated with the delays, which I'm going to talk about later. So the process of weaning has to be very serious, and it should begin with screening patients for readiness to start weaning, which is followed by the spontaneous breathing trial that we all, you and me, both know. Now, the method of SBT, because a lot of juniors are here, I thought I just touch on the method of SBT or the spontaneous breathing trial, which is to be conducted while the patient is still connected to the ventilator circuit or at least to the TPs. And if still on ventilator, the patient should have minimal ventilator settings, that is pressure support of 5 to 7 or PEEP of 1 to 5. That is to overcome the increased work of breathing through the circuit. And initially, the trial should last 30 to 120 minutes. But if the patient is supposed to be not tolerating SBT with that 120 minutes, that should be considered as a failure. So in general, if the patient has been ventilated for a shorter period of time, then this SBT time can vary. And 80% of patients who tolerated this time of 120 can be permanently removed from the ventilator. That's what we thought. And currently, though, the best SBT for extubation is not well defined. This is not for weaning. For extubation, not very well defined. And this is still a wide variety of SBTs in different levels of pressures around the world. So the best SBT to identify the readiness for extubation has been tried and tested in many places and many studies, and found approaches around the world vary widely, which is having a lower level of SBT, which is with the pressure support of 8, yield a higher rate of successful extubation than non-assisted SBT. That is a finding, because they found if you have given some level of assistance, which gives a higher rate of success. The previous speaker also touched about the lung ultrasonography, and in the weaning too, that has a place, which enables the assessment of the respiratory muscles, which is the diaphragm and the accessory muscles, and the lung aeration. I mean, she nicely spoke about using that in the RDS and the management of the ventilator settings. But even for the weaning, we can get idea of the respiratory muscle activity as well as the lung aeration, how morphologically it is well aerated. And they give the score, as she said, which is called the LUS score. And higher scores indicate the collapse areas and are associated with extubation failure. So you are not going to handle something which is not to be feasible. Extubation maneuvers, again, is very few studies were done on the extubation maneuvers in the world. And recently, a systematic review on the use of suctioning and productive positive pressure during extubation was unable to recommend either approach over the other. So another study which I'm going to touch on later. And again, extubation failure also defined as many of the parameters, but I'm just to touch on maybe few of this at least. More than one of the following, like respiratory acidosis, low saturations, low oxygenation, high carbon dioxide, patient being agitated. So either objective or subjective way, you can judge the extubation failure. So this particular study, which I'm going to talk about more, is the weaning from mechanical ventilation, speed it up and make it safe, which is talking about the current standard of the weaning process. That's what I'm expected of to talk to you about more. We all know there are two traditional approaches, which is the two sequential phases. One is to start by screening the patients, that is to early detection of the patients who are eligible to tolerate it. And then the confirmatory test through the SBT trial. That's what we knew already. But in recent years, two new aspects have been developed to add on to this thinking. And that is a risk stratification for extubation failures and application of the non-invasive respiratory support after extubation. So these are the two things added to what we knew. One, to screen, then to test it with SBT, but add to that, have a risk stratification and application of the non-invasive strategies. And the new approach requires dealing with all these four aspects simultaneously. That is stratification, screening, SBT, and the post-extubation support. So, as if the screening, we all know this, there are current standards of screening, like subjective criteria, like whatever the reason that we have started the patient being ventilated has to be resolved at least partly. So resolution or stabilization of the condition, and the minimum level of continuous sedation and respiratory rate more than 6 and less than 35. And objectively also, we screen the patients to be fit for weaning is by having good hemoglobin levels, iron levels are okay, good protective devices, PF ratio, and things like that. But again, as I told you earlier, to see whether the SBT is tolerant, again, we can use the subjective criteria and objective criteria. As I told you, subjectively, patients should be well enough, woken enough, profuse, or things like that. But objectively also, the PO2, PCO2, pH, respiratory rate, and respiratory rate over the over 35 and 50% oxygen, things like that, and the heart rate. And the new two things, that is the risk stratification for failed extubation. There was a model which is talking about the three factors, which is only had the age and the chronic heart disease and the chronic respiratory diseases, that most of the time that even though it is not as said to be risk stratification, we used to think about it. But now there is this new one, which is a 11-factor model. Yeah, you give a lot of factors into consideration: the age, the heart failure, the moderate or severe COPD, Apache score, BMI more than 30, secretions if it is more than 2 times within the 8 hours prior to extubation, or the comorbidity index, upper airway related problems, more than 1 failed extubation, SPT trials, development of hypercapnia, more than 7 days IMV. All these are given a value to stratify the risk. And the fourth one, which is the non-invasive ventilator support after extubation, also should be said to be individualized, just like the previous talk. Even to use it during the ventilatory strategies or to prevent the intubation, to start the intubation, it is being used just like this. This also should be individualized based on the individual risks. So the recommendations had been made to prevention of failure by using this risk stratification, and they say low risk patients, you can use the 24-hour course of high flow, and in intermediate risk patients, which is supposed to be the less than 3 risk factors without obesity or hypercapnia, we can use a combination of NIV plus the high flow for 48 hours, and a very high risk patients where more than 4 risk factors and obese and hypercapnic, we can use the optimized NIV with gas conditioning like hump nose or something like that, and intermediate interface, and appropriate interfaces should be used. So the key is to avoid any weaning delays, and early detection is the keyword that we need to think about. But when we are screening the patients, we need to think about updating of this for several reasons. For an example, the current recommendation applied to low or intermediate risk patients may result in unnecessary delays and associated complications. So the patient can have ICU delirium and things like that if you delay the weaning. And the predicting SPT success using parameters, which is we use to take the rapid shallow breathing index, that is respiratory rate over tidal volume, and it should not be confused with the extubation success prediction. And these two demanding non-respiratory screening criteria, such as the use of noradrenaline and other cardiovascular supports and all, and maybe inadequate sedation protocols, also may delay the increased result of these increased weaning delays of these patients. And regarding the use of inotropes, no specific recommendation have been made, even though we say, but sometimes even with inotropes, we start weaning if the patient is having any cardiac problems. So the role of PEEP during the SBT is still to be clarified and is currently under the study, because we were talking about the pressure support, but the value of PEEP is still to be discussed. And it seems commanding to individualize the SBT based on any patient's individual risk, screening, and the therapy. And I'm going to take you through to a visit to a few studies that which is going to be maybe complicating you, maybe giving you some answers. Let's talk about few of the studies in the recent past. Influence of drugs used for sedation. We all know different classes of drugs we are using for sedation, propofol, midazolam, any other non-opioids, and all are having different effects on the respiratory patterns, and this may influence the weaning and outcome in mechanically ventilated patients. That was actually found by the Wean Safe study. Another study, which is the Wake Up and Breathe protocol, that pairs the daily spontaneous awakening trial, which we used to do it, and we used to interrupt the sedation in the morning, and we tally it with the daily SBT trial, which I earlier spoke about, and the results were found to be better, and it should become the routine. Actually, it has become the routine. We all know we give a sedation holiday when it comes in the morning, interrupt the sedation, and try with the SBT early as possible to see whether the patient can be weaned. The electrical impedance tomography, which is being used for many situations, is being used for this as well. And it is a non-invasive imaging technique, and it can get an idea about the distribution of air inside the lungs based on the changes of the electrical impedance. And it gives you gives a lot of parameters, multiple parameters like tidal volumes and all sort of things, but beautifully gives the homogeneity of the air aeration of the lung. That can be used to see the weaning strategies. So this is the tidals and FRC is being taken, and it can also assess the changes of ventilation with the PEEP or the SB or whatever the supports that you are giving. So high lung inhomogeneity was found to be SBT failure. So you're not going to try on those patients unnecessarily. And of course, it can be used for any other larger studies still waiting to. Another study, effects of aggressive versus conservative screening and confirmatory tests. And again, it says combining these with the aggressive screening with preventive PEEP and a conservative SBT will reduce the time. What about the positive end expiratory pressure, role of the lung and diaphragm ultrasound? Yes, and even previously it was discussed about the ultrasound yet again. This can be checked on the diaphragm and the other muscle functions. So does the effect of PEEP on that, right? So when you have a PEEP, which is positive end expiratory pressure, and what happens with that to the diaphragm and the muscles? And in patients with acute exacerbation of COPD, this is a very handy tool. And during weaning, combining this with the ultrasound of the lung, diaphragm, and the heart together will give you very, very valid information to you to aid for your weaning. Weaning of the non-COPD patients with high risk of post-extubation respiratory failure, which again, another good study, Wean study, and again found NIV alternating with the high flow. And that found if you have a high risk of post-extubation respiratory failure with a lung ultrasound of more than 14, and prophylactically using the NIV, alternating with high flow, significantly reduce the post-extubation respiratory failure. And to my practice, I used to do this because even though I don't have LUS all the time, but still for all, we used to do this use of the prophylactic NIV alternating with the high flow if the patient is non-COPD. So then COPD patients, again, NIV alternating with high flow, found to be having a significantly decreased the risk of reintubation. So the effect of the post-intubation NIV with active humidification is another one. So NIV with high flow alternate, NIV with active humidification versus the HF high flow found that NIV with active humidification was superior. So you can use HME or something and use it. So another one, effectiveness of the high flow versus the NIV with the conventional oxygen therapy. Again, it was found to be superior. The NIV is superior to all and then can be used in alternation as well. Another nice study is the effect of lung volume preservation during spontaneous breathing. That is, we all know when you do the suctioning, when you keep the PEEP, when you keep the CPAP or the PEEP, and you disconnect the ventilator circuit, that will be losing. But if you keep on suctioning, that is losing as well. Now, this was a very nice study. Yet to find out, you can launch a study on this. Suctioning might promote the de-recruitment. So the study aimed to preserve the lung volume without suctioning. So you can do the suctioning earlier, but when you extubate, don't do the suctioning. It is on the way to study. So the high flow versus Venturi mask, obviously the reintubation rate did not significantly differ. And very new studies have been come up. So the reintubation rate of the Venturi mask is almost not very high though, but NIV with alternating is the best thing to do. So abdominal functional electrical stimulation also is being a very nice study. It's still being carried out. That is to use the external evaluation of the abdominal muscles being stimulated by electromechanically. And there are so many studies on predicted for weaning failure in adults. And to identify patient as high risk for weaning failure is a variety of potential predictors. But most frequently investigated predictors like the rapid shallow breathing index, which is the respiratory rate over tidal volume more than 105, we say it is not valuable. And the diaphragm thickening fraction by the ultrasound or things like that. But overall, the incidence only is not going to give you the answer. This is an extensively broad concept as it includes the various scenarios. It could be aggressive screening without performing SBT and the risk stratification, aggressive screening with intolerable SBT. So as I have shown in 4 aspects here, there can be different combinations. Screening, tolerance to SBT, application of the NIV, and all the 4 strategies I told you. But to date, the last one, which is the aggressive screening, tolerance to conservative SBT, and the risk is the only one checked on this. So, Chairman says, future research should be conducted in line with the international weaning definitions and further investigations. And we face the need for redefining the weaning process. The evolution of medicine towards personalization should include weaning as well, with the detection of subgroups with different clinical behavior. So you cannot say one shoe fit for all concept here too. And thank you very much for your kind listening. Thank you.
Thank you very much, Professor Vasanti, for that very extensive and practical aspects to weaning strategies. Next is a lecture on preventing ventilator-associated pneumonia, again by Dr. Sin.Man Lam. And over to you.
Thank you. So my second talk will be on preventing ventilator-associated pneumonia, or VAP. We will first define how we diagnose VAP, and also the evidence for some of the individual measures and ventilator-associated pneumonia prevention strategies. So VAP is very relevant to us in the ICU because it accounts for approximately half of all the nosocomial pneumonia, and is the most common infection in patients needing mechanical ventilation. And it does have its attributable mortality said to be around 10%. It prolongs ICU and hospital lengths of stay. And it consumes a lot of antimicrobials and imposes a significant healthcare cost. So it is very important to prevent VAP, and it has become a cornerstone quality improvement program for most governing bodies in ICUs. But VAP is notoriously very difficult to diagnose. It's because the symptoms and signs of VAP has a very low sensitivity and specificity when compared to the histological gold standard. We simply cannot do biopsy for all our patients on mechanical ventilation. It's too risky. So what we rely on to diagnose VAP is a combination of symptoms and signs and radiological criteria, sometimes even with microbiological confirmation. But there is a number of published criteria for VAP in the literature. And as you can see from this study, which prospectively included patients who were ventilated for more than 48 hours. And when they applied different diagnostic criteria or different defining criteria to these patients, the occurrence of VAP significantly varies between more than 40% to down to 4% only. So we have to be consistent with how we measure VAP, especially when we want to compare our temporal difference in its occurrence and see how our preventive measures is impacting the occurrence. And it's even more important for external benchmarking because we will need to know how VAP is diagnosed in the other settings before we can compare, right? So this is one problem with VAP. The other problem with VAP is because of its subjectivity. The signs and symptoms, whether you hear crepitations or auscultation, and even interpretation of radiological images is very subjective. And therefore, this lack of objectivity has been criticized in the definition of FABs. And therefore, in 2013, the CDC in the United States replaced definition for FAB with ventilator-associated events, VAEs, which instead of focusing on the signs and symptoms and radiological imaging, it focuses on a deterioration in oxygenation, whether the patient needs to have a consistently increased PEEP or consistently increased FiO2 in order to maintain saturation. So because of this objectivity, this parameter is very amenable to automation. You can incorporate this into electronic health records to capture this, and it will save you a lot of manpower. But because a complication of mechanical ventilation that leads to an oxygenation failure does not just come from pneumonia, it can also be caused by other causes. Therefore, this measurement lacks sensitivity and specificity for FAB. And the impact of currently in place ventilator bundles on its incidence is still being studied. As we have said, pneumonia is only one cause of VAE. VAE can also be caused by atelectasis, by ARDS, and sometimes the cause is unknown. So only 1/3 of VAE is due to FAB. And the other way around is true too. Only 1/3 of VAP of FAB constitutes VAE because it only captures those severe enough to cause an oxygenation failure. So the two is not equivalent. But is this parameter, VAE, still worthwhile to monitor? It is, according to this EU VAE study, which looked at the incidence of VAE outside United States. And it found that patients with VAE compared to patients without VAE has significantly more days on invasive mechanical ventilation. They required more ICU stays, hospital stay was lengthened, and there was a trend towards mortality. So VAE is relevant clinically. Only when the diagnosis of FAB is well defined can we do surveillance and monitor the impact of various prevention strategies. So we will next move on to various prevention for FAB. And FAB is caused mostly because of the presence of an endotracheal tube, which splits open the glottis, allowing pathogenic organisms colonized in the oral cavity, in the digestive tract, to enter our lower respiratory tract and cause inflammation and infection, and therefore FAB. So the core measure to prevent FAB, firstly, is to limit this duration of mechanical ventilation. And what we can do is to avoid intubation and re-intubation with non-invasive respiratory support, as we talked about in the first talk. And also to have protocols in place for paired daily spontaneous awakening trials and spontaneous breathing trials for patients without contraindication, as talked about by my previous presenter. Also, minimizing sedation is important. As Shihabi has shown it with this study, sedation intensity in the first 48 hours of mechanical ventilation independently predicts survival as well as the duration of mechanical ventilation. Sedation intensity was defined in this particular study as the average of negative RASS score in patients who was under mechanical ventilation. The choice of sedation was also important. Using non-benzodiazepine sedation improves the duration of mechanical ventilation and subsequent delirium also. What about head of bed elevation? Head of bed elevation is a simple measure we can do at the bedside. Radioisotope studies have shown that by simply elevating the head of bed to a semi-recumbent position, 30 to 60 degrees, you can reduce the amount of radioisotope recovered from the endobronchial secretion compared to if the patient was nursed or in a supine position. And therefore, more recent analysis also confirmed that the use of semi-recumbent position versus a supine position can reduce clinically suspected pneumonia, but it does not have any impact on other objective measures like mortality and length of stay. And the evidence for this is not too robust because you can see that the numbers included is very small. These are very early studies. But because head of bed elevation is that simple and it comes without any risk, it is usually incorporated as an essential measure in ventilation bundles. So other essential practices as recommended by professional bodies also include providing early enteral versus parenteral nutrition, not to change the ventilated circuit on schedule, but only when it is visibly soiled, and also to provide oral care without chlorhexidine. This, because many of the ICU-acquired infection is gram-negative microorganisms as well as fungus that reside in the digestive tract. So by regularly cleaning we can hopefully reduce the infectious complications. So oral care, daily oral care is in line with this selective digestive decontamination, this selective decontamination of the digestive tract. But this is more controversial. This practice, SDD, is routinely practiced in some of the Northern European countries, like in the Netherlands, where they apply a paste comprising usually antibiotics like nystatin, antifungal, and colistin, and tobramycin to tackle the gram-negative and fungal microorganisms. And they also instill it in the gastric tube for the digestive tract. And some of them will also incorporate intravenous antibiotics, usually third-generation cephalosporins, to eradicate any microbials already in the respiratory tract. So it has been found by Northern European countries to reduce the FAP occurrence, and also there is an evidence for mortality benefit. And recently in Australia, this Australian study outside of Northern Europe has tried to look at select SDD compared to standard care and see whether it can improve mortality. The outcome was not different, but if you look at the confidence interval, it does include a clinically significant benefit. But again, other measures were not were not the same. And what is the problem with SDD is that most of the evidence comes from countries with a very low resistance rate of antimicrobial resistance. And so the evidence for settings where the antimicrobial resistance is higher is unknown. Prophylactic antibiotic can also be given through inhalation as a preventive measure of FAP. This meta-analysis includes the more recent Health study, which randomized patients who have been ventilated for more than 72 hours to receive up to 3 days of inhaled nebulized Amican versus standard care. What they found in this meta-analysis was that the risk of FAP occurrence was significantly reduced by inhaled antibiotics, especially if the inhaled antibiotic used was aminoglycoside. But there is still a concern with the use of prophylactic antibiotics because over the long term, will it increase antimicrobial resistance? So some investigators have tried to limit the use of prophylactic antibiotic in high-risk patients, for example, in brain injury patients. In this RCT, they randomized patients who had SAH or a stroke or a brain trauma to receiving either a single bolus of ceftriaxone intravenously to placebo. And they were able to find reduction in early FAP occurrence, that is in the 2nd to 7th day of mechanical ventilation. And they were able to show an increase in ventilator-free, antibiotic-free, and also other lengths of stays, and reduce day 28 mortality. But more longer-term mortality, like day 60 mortality, was not different, because the mortality would honestly largely be determined by the underlying neurological deficit. But they were able to show a reduction in early FAP occurrence. So there are also other measures that has not been shown to consistently reduce FAP rate, or it has not been shown to impact the objective outcomes like mortality, and these are generally not recommended. For example, the use of different designs of ETT tubes, and also the use of probiotics. So there are a large number of measures that we can do to prevent FAP. And what is important is bundling these measures into a ventilation bundle helps to reduce mortality further. So despite different bundles having different measures, it still has been shown to reduce mortality. But we know preventing FAP is very manpower intensive. So apart from all the individual measures, having a ventilation bundle, the other determining factors whether you can reduce FAP is your staffing, whether you have adequate manpower to comply with all these measures, whether it's in terms of the nurses or in terms of the physician. So it is recommended to start off a FAP prevention strategy by focusing on the more evidence-based measures, and those that have more simple to apply and have associated with less risk. And then moving on to incorporate other measures, and eventually sharing your experience too. So to conclude, FAP has significant attributable mortality and morbidity and economic burden, and it's too important to ignore. The different diagnostic criteria have been published, and VAE is an attempt to make it an objective surveillance tool. But bear in mind that not all VAE are VAPs, and not all VAPs are VAE. And the core measures to prevent VAP tackles its underlying pathogenesis by limiting the duration of mechanical ventilation, preventing colonization of the aerodigestive tract, and prevent aspiration into the lower respiratory system. And a successful FAP prevention program requires staffing, education of the staff, infrastructure, and also IT and laboratory support. So that's all for today. Thank you.
Thank you very much, Dr. Lam. Now the symposium is open for discussion.
Thank you both for excellent talks. My question is to Professor Lam. It's good to see you in person in Sri Lanka. Though your talk was on prevention of WAP, my question is more on PCR assays like BioFire and ARA. How do you see that? How do they place? How do you see them in a diagnosis of WAP and antibiotic stewardship? The PCR platforms that are available at present.
Sorry, can you repeat that?
My question is on more of diagnosis of WAP, though you talked on prevention. We have PCR platforms like BioFire and FilmArray. I would like to, if you could share your experience on the utility of these things in diagnosing WAP and their role in antibiotic stewardship.
Right. Because BioFire and these platforms, they are quite expensive. So in our setting, we mainly use it for community-acquired pneumonia. And because they do not include many of the FAP microorganisms that might cause FAP, such as Citrobacter, etc. So to cut down costs, we reserve these platforms for diagnosing community-acquired pneumonia instead of VAP. I'm sure if financial concern is not a problem, you can use it to diagnose, because they have also, they can detect Acinetobacter and other drug resistance.
Yeah, the newer platforms, yeah, they detect drug resistance as well. And as of present, the universities have these platforms, and it will cost about 100,000 for a test. But when you compare with the antibiotics, and when you take into concern the antibiotic stewardship aspects of it, do you think that in the future they will have a role to play?
Well, still, financial concern is a problem for us. I think we need to have more data on that to see whether the economic, whether there's a cost benefit in the use of these platforms to prevent, to know which antibiotic to target. But by that time, you would be already treating the FAP, and we're talking about hoping to prevent its occurrence.
Another question from to Dr. Lam. Now it's very important to correct the hypoxemia in ventilating patients. But on the other hand of the spectrum, hyperoxemia also increases mortality and morbidity, especially when we are dealing with fibrotic lung diseases, etc. So now we do have precise targets, such as in COPDs, target saturation to be maintained. But in other conditions, like in overall, in critically ill patients, when you're ventilating, what are the targets, what are the oxygen saturations you must maintain to prevent the hyperoxemic lung damage?
Yeah, this has been very widely looked at. There are a lot of research on the oxygen target, and because of the time, I did not cover this aspect. But you're right, apart from preventing hypoxemia, we should also be preventing hyperoxemia. Especially, there's evidence to suggest that the outcome is worse for subsets of patients, like post-arrest patients. If you give them too much oxygen, the outcome is worse. So there's some recommendation, general recommendation. In COPD patients, we usually keep them lower, 88 to 92%, for example. And for other ICU patients or in general ward, maybe 94, but definitely not above 97%. For patients who are requiring a significant amount of oxygen, like they're using more than 60% FiO2, we can shift this target to a lower end, like 88 to 92%. There is recently a study on personalizing oxygen targets. So it may, because all these studies before, we do not see a very significant benefit of using a very low, targeting a lower oxygen benefit. The evidence is controversial. The one reason is possibly because it doesn't work for every patient. Some patients may benefit with a lower target, while others may benefit from a higher target. So there's a recent study on using machine learning to personalized oxygenation target. And we see signals that, for example, patients with sepsis, they may need a higher target, whereas patients with neurological injuries, they may need a lower target to benefit. So we're entering an exciting era where personalizing oxygen target might be a way to go.
Thanks.
One question actually to Professor Pinto, because this one of the area of my interest, and when I went to some conferences abroad, that you're talking very kind of significantly about this. These basically automated weaning protocols, and they have. What is your experience regarding this AI-used automated weaning protocols without any human involvement? So there are one protocol as such that in my experience is IntelliVent AVS. That is one of the automated protocols. There's no critical care vision is involved in the machine itself. Assess all the parameters you said, and then it's weaned down. And do you have any experience or any machines that we have in Sri Lanka with such facilities? And what is there any is there any benefit, added benefit in compared to the manual weaning versus automated weaning?
Yeah, thank you for asking the question. Actually, I didn't open that area because it's very vast to talk about. Yes, even they have studied a lot of predictors. Now, the time has come to move out from individualizing the predictors. It has to be collated all, and the machine learning is a very good outcome brought up by that. But yet again, still the studies are being taking over whether, as she very correctly said, everything is being individualized. So whether that individualization can be really tackled by the machine learning is a question to date. So that is why this has been like any other diagnostic test. What they recommend is, even though we can use the machine generated models in AI, using of the AI, still we are not using it in Sri Lanka, to be honest, but there is a scope for that in the world. But yet again, the new studies were discussing of individualizing and personalizing, and to that extent, whether the machine learning is going to fit in is a question to date. But I agree to you, there are so many models came up with the AI tools.
It's quite rapid.
Yes.
Within few hours, within 24 hours, they just wean. I mean, they say that most of the ventilators, pneumonias and everything are very less because that the machine itself and take all the time and within very few hours actually they wean. I mean that some of the studies that they discuss, I'm not sure what is the fact, how practical it is, but it's a very rapid weaning protocols actually.
Yes, I too agree to you. It is rapid weaning protocols are there. But again, the very recent articles came up to say whether we are really tackling it, individualizing it. True enough, but if you just put all the parameters, that will give you an idea. But you just heard the other two, the WAP and the other ARDS as well. You know, there are different, the homogeneity is not equal because there are so many ways these presentations come up. That is why they say it has to be a decision made during the ward round with a lot of people. There should be teams only to involve to weaning, to come up to each patient to discuss the possibilities daily, to give the holidays, sedation holidays and all. Discuss, it has to be a respiratory physician, respiratory therapist, the nurses. That has to be an individualized decision with the team. In that, to using the AI models to fitting is little questionable at times. Certainly, this works in the neonatal age groups. For the children, the pediatric age group, this is something that has come up more to adults. Did that answer your question? Yes. Hope for the future. Hope for the future. Yes. Yes. Thank you.
I have one more question to Professor Lam. Basically, thank you very much for your two interesting talks. So now the ERS guideline or the recommendation on acute hypoxemic respiratory failure came up in 2017, and then the ESISM also has come up with the statement. Now you were mentioning about this study Renovate. That's something done quite extensively compared to the previous studies analyzing the subgroups. So do you think it has changed, or that this study has any implication on the previous recommendations or guidelines?
On which
I'm
group
talking
of
about the
patients?
Renovate study, because all the previous studies were checked on the COVID patients and the previous hypoxemic patients. But this study, what you were talking about, Renovate study, and in that you were talking about a lot of subgroups, like immunocompromised, non-immunocompromised, acute, like that.
Yeah. Right. There were 5 subgroups.
Yeah.
Yes. So the evidence is quite clear for the acute hypoxemic respiratory failure patients who are immunocompetent, and also for the COVID patients. But we cannot conclude from that study regarding patients who are immunocompromised, and also for AE-COPD patients, because a lot of them cross over, and also there's the confidence interval. You can see that it includes clinically possible harm from high-flow nasal oxygen. So I will not use that high-flow nasal oxygen as a first-line therapy for these patients. And in APO, because the many of the patients were already put on NIV and they were excluded right away. So it cannot be extrapolated to these patients. Maybe only the less severe APO patients, you can try the high flow. So for these traditional first line where NIV we're using as first line, I will continue to use NIV. Only if the patient cannot tolerate and during NIV breaks will I use high flow nasal oxygen to couple.
Thank you.
Thank you very much. From that, we conclude this symposium of critical care. And once again, thank you very much for the both speakers, Professor Pinto and Dr. Lam. And for giving away the token of appreciation, I would like to invite Dr. Manin Piris to give away the token of appreciation for the speakers.